Now to talking about some really common conditions that people with neck pain might be living with. And we'll start here by talking about osteoarthritis or spondylosis. Spondylosis has some technical differences between the kind of osteoarthritis that we might see at a knee or a hip. Um, but in terms of the pathophysiology, the processes are very, very similar. What we see with spondylosis, this osteoarthritis of the spine, is a progressive loss of range of motion. For a lot of people, it's essentially a painless progressive loss of range of motion, and that's related to these distortions or, bony relationships that are not quite working for us. So what we see in this picture is an X-ray of a cervical spine, and if you look closely, you will see where the vertebral bodies have reached out with little osteophytes, bone spurs, if you like, and they have actually fused together. If this doesn't happen to irritate nerves, this is not a painful process, but it does mean that this person now has a permanent loss of range of motion. One of the big problems or challenges, I should say, with spondylosis and arthritis in the neck is that what we see in imaging with X-rays or MRIs often has very, very little to do with what symptoms a person experiences. And we have tons of data that demonstrates this point. And so while sometimes an image can give us very important information, for instance, if there's a crack or a break or a disc bulge, that can be, very, very important in terms of what kinds of decisions we make. But there is not always a consistent cause and effect relationship between what we see on a film and what a person reports to us, which brings us back to Whitney's point about getting a really thorough history of what kinds of stresses this person's neck has gone through. The last point I want to make about spondylosis at the spine, and this is a thing that makes it different from osteoarthritis at our other synovial joints, is that it can involve thickening and stiffening of some really important ligaments. And this can include the anterior longitudinal ligament that runs down the front side of the vertebral bodies, but it can also involve thickening of the posterior longitudinal ligament, which is actually running inside the spinal canal. So we're talking about the extra ligaments that we see in spondylosis that we don't see in osteoarthritis at other synovial joints. And it so happens that I have a cervical vertebra of a seal, and I will hold this up on my black background. Maybe that how are we doing with that?
That's good. Yeah, we can see that
that
now.
work out okay?
Yeah.
So we know it's a cervical vertebra because it has foramina in the transverse processes, and that's where the vertebral artery comes up.
Mhm.
But the other point I want to make is that here in the spinal canal, on humans, and I will assume seals too, there is a ligament that runs on the anterior aspect of the vertebral canal, and another ligament that runs down the anterior aspect of the vertebral body. On the vertebral body, this would be the anterior longitudinal ligament. This is something we could potentially palpate if someone had no guts, right? And then within the vertebral canal, right
There we go.
here is the posterior longitudinal ligament. And if this ligament thickens and buckles, it can put pressure directly on the spinal cord. And that is something that we see in spondylosis that we don't see in other kinds of osteoarthritis. Okay?
One other thing, can you hold that there for just a moment too? I just want to call people's attention to if you look at a comparison between the anterior and posterior longitudinal ligaments, you'll notice the anterior longitudinal ligament is far wider from left to right than the posterior longitudinal ligament inside the spinal canal. So that ligament's pretty thin inside there. And then it is in direct contact with the intervertebral discs between each vertebra. And so if there is excessive disc compression, and we're going to talk about that again in just a few moments, a little bit more, but if there is excessive disc compression in the cervical region, or anyway, this is true throughout the spine, that disc will have a tendency to push straight posteriorly, but the posterior longitudinal ligament stops the disc from pushing out in that direction and makes it squeeze out to the sides where there is no border. And that's where it hits nerve roots. And that's one of the reasons why you're vulnerable to having nerve root compression out to the side from disc herniation, which it's not great, but it's definitely beats getting straight posterior protrusion and pressing on your spinal cord in that region. So, which of course can
which can
happen
happen,
under certain
but
situations. Yeah.
it's relatively rare. Yeah.
Yeah.
Okay, good. Well, thank you, Seal, for helping us out.
All right.
All right, so this is what we were just saying, is that the stenosis of those vertical ligaments, particularly the posterior longitudinal ligament, can create a dangerous kind of situation.
Mhm.
A closely connected pathologic condition of the spine is facet joint dysfunction. This basically refers to osteoarthritis at the facet joints, which are the only synovial joints that we're talking about, where those facets meet. So, Whitney, do you want to talk to us just briefly about chronic and acute facet joint dysfunction?
Yeah, so facet joints, we said, since those are the only two locations where everything, where those vertebrae contact directly with each other, this is one of those places that we tend to see more chronic applications of the facet joint disorder. Like, let's say, very poor forward head posture positions where you're sticking your head forward for long periods. That tends to keep the spine in extension. And when the spine is in extension, those cervical facet joints are further compressing each other. That with your head weight on top of it. And then if you are in a forward head posture position, the muscles of the cervical region are highly contracted to try to hold your head up and keep it from falling forward. And that additional compression load from the muscles contracting increases the facet joint compression as well. So this may be, pain and discomfort when turning your head to the side or, bending forward in certain positions that might further compress those facet joints. That's when you'll tend to feel it. But you can also have that facet joint compression occur from an acute injury. It's not as common from acute injuries, but think of like the person who's, diving into a shallow swimming pool and hits their head on the bottom of the pool or something like that. There's going to be very significant loads, compression loads on the facet joints, or maybe you're, pulling something off of a very tall shelf and it falls down and hits you on the head. That's that high level compressive force on there can cause damage or irritation to the facet joints. But most of what we see with those facet joint problems tends to be more of chronic loading over periods of time. And then again, because of chronic loading, the facet joint contact surfaces become irritated. And this is what is a lot of the osteoarthritis development as well.
Right. And this can present with symptoms that are muscular, right, or musculoskeletal,
Yeah.
and nerve compression issues as well, because everything becomes inflamed. But it is probably not realistic to suggest that even the most skilled body work is going to reach inside the facet joints to, knit things back together and make everything smooth again.
Yeah. So one of the important things I think to think about from a bodywork perspective about this is, we won't necessarily change the joint contact surface, just like we're not going to do that for anybody with knee osteoarthritis either. But that doesn't mean what we do can't be super helpful for that person, because a lot of times the problem with the osteoarthritis is the pain sensations that's felt, because there's a lot of people that have degenerative joint contact surfaces and no pain whatsoever. So what we're really trying to do is to manage the pain sensations that come along with it. So even in an osteoarthritic condition or facet joint problem, a lot of the superficial and gentle and just very soothing kind of work that we can do with the soft tissues to address the nervous system's responses in the cervical region can be super helpful for these people.
And that loops us back to that disconnect between what someone's MRI or X-ray shows and whether they are experiencing pain.
Yeah.
One of my favorite studies about this was when a number of volunteers got X-rays of their neck, and the films were shown to, I forget what kind of doctor, neurologist or orthopedist or something, and they were asked to predict where those people had pain, which they did based on the X-rays, but none of the people had pain.
Yeah. Mhm.
They were just random people taken off the street to x-ray their necks.
Mhm.
And, you know, so this again brings us back to um, expectations, right? And the biases with which we walk into situations. And massage therapists can be part of that as well.
Yeah.
Let's talk a little bit about